Meeting is being recorded. Okay.
I think we can start. Good evening, everyone. Welcome to the 9th webinar of AOMSIKerala. Our topic for today is otoplasty or bacterial correction. And our speaker is Dr. Varun Nambiar. And our moderator for the day is Dr. Vineesh Udayakumar, Professor Dr. Vineesh Udayakumar, who is into aesthetic surgeries and orthodontic surgeries and implant practice. Dr. Vineesh is currently based in Tiruvalla and he has his own private practice. I request Dr. Vineesh to introduce Dr. Varun Nambiar, our speaker for the day. Over to you, Dr. Vineesh.
I think Dr. Vineesh has left the meeting unknowingly.
We'll just take a second. He'll join back now, I think. Yeah.
Sure.
Is he back online?
It shows that he has left again.
Yeah, he's back online.
Yes,
Please make
he's
the
back here.
Vineesh, you can introduce Dr. Varun.
Hi, good evening. Today I have pleasure in introducing Dr. Varun Nambiar. He finished his PG from AJ Shetty during the year 2015, and right from 2017 he's practicing exclusive facial aesthetic surgery. And I'm happy to say that he has got many centers from Kochi to Kasaragod. where he specializes on facial aesthetic surgeries. And what I heard and what I know is that he does a lot of rhinoplasties and otoplasties under LA. So when I heard about the topic bat ear correction, um, I had a different idea of what it was. Then later, when I just went through the articles, understood what it is, and Dr. Varun will be explaining about that in detail and what are the options. But what I understand is it's like many people are affected with bat ear deformities, and many are actually victims of harassment or bullying, pointing about the defect, and these people usually suppress that all those feelings, and they try to hide the deformity by having a excess hair. And I must frankly, I had been one of the bully uh, who used to pinpoint about this ear deformity when I was a child to my cousin. So just now I know that it is what it is, and this specialty is actually not very established among our field, that is oral and maxillofacial surgeon. And Varun is one of the very few maxillofacial surgeons in Kerala and also in India who is practicing this correction. And he does couple of cases. That is, I think he has around every month he does around 3 to 5 cases of bat ear correction, if I'm not wrong. Okay, and I'm okay. Dr. Varun, can you enlighten us about the topic? Welcome on behalf of AMSI.
Over to you, Varun. You can start the session.
Dr. Varun, we are not able to hear. Dr. Akhilesh, are you able to hear?
Varun, your microphone is muted. Yeah. Okay, can you start from the beginning? We are not able to hear the first part. Could you please start from the beginning?
Very thank you to Dr. Vineesh for introducing me. So let me begin my journey from 2015. Any maxillofacial surgeon for any chance after passing MDS comes out with many questions. Which part should I actually take after maxillofacial surgery? Whether I should go and concentrate on traumas, whether I should go for orthodontic surgery, cancer surgeries, cleft surgeries. So we all have passed this path, which area to be focused. And there are many people who say that the one who does real bone surgeries are the real maxillofacial surgeons. Whether is it the truth or a myth, it is always there between us, and it is there in anyone who is coming out as a maxillofacial surgeons. So which area we should actually select? That is actually a very confusing topic for all the freshly passed out maxillofacial surgeons. As you all know, right now in Kerala, there is almost like 276 AI cameras, which is being spreaded from Kasaragod to Trivandrum. And people started wearing helmets very oftenly. So what is happening? Almost the trauma, which has been the bread and butter of maxillofacial surgeons, has come down drastically. So many studies have shown that almost like 3 times it has reduced. The facial trauma has been reduced. And what about orthodontic surgeries? Orthodontic surgeries in people, the early intervention orthodontics and myofunctional appliance, and right now the big name, that is TAD screws, that is temporary anchorage devices, has already reduce the probability of orthognathic cases. So where we should go? So where exactly is the treasure? So in such a case, every maxillofacial surgeon should search for a treasure to survive, to meet their needs. So here comes my topic, that is facial aesthetic surgery. So my dear friends, facial aesthetic surgery is like an ocean. It's a huge opportunities. It's lying down there, but nobody, or it's people right now. Some people are coming out. Most of the maxillofacial surgeons coming out as freshly passed out maxillofacial surgeons are keen into facial aesthetic surgery. They want to learn facial aesthetic surgeries, and I have to tell you that this is a real treasure. It's a gold mine. You definitely have to go in and dig the gold out. And here comes the facial aesthetic surgeries like rhytidectomy, autoplasty, where I'm going to talk today, rhinoplasty, blepharoplasty. So the list go on. So you all have to concentrate on facial aesthetic surgeries for making our needs. Why? Because right now in this 21st century, everybody wants to look good. So we have to tap that. Why? Because every aging people wants to look younger, and some people is having bad ear or protruded ear. And here comes my topic called autoplasty. These are some of the things which I'm going to cover in this presentation. So basically, autoplasty is the ear surgeries are basically called as autoplasty. Prominent ears, as the Dr. Vineesh has introduced, said it is actually a relatively common auricular deformity. The aesthetic and the psychological sequel of this deformity can be profound. Normally, functioning there doesn't have any problem, and a protruded or a prominent ear doesn't have any problem with the normal functioning of an individual. But the social bullying is the main factor which leads them to into surgeries. The term autoplasty refers to the surgical changes in the shape or the position of the ear. Auricular surgery was initially described in the 7th century in a writing called by Susruta. Historically, Diefenbach, as you have, Diefenbach is a very renowned surgeon. He has listed so many surgeries in maxillofacial surgery. Diefenbach is bestowed with the honor of being the first one to describe the correction of auricular prominence. But the first written prescription of autoplasty was by Ellie in 1881. And the surgeons who treat this deformity should have a thorough understanding about the anatomy of the prominent ear also. So if you go to the embryology, the external ear development starts during the 3rd and the 12th week of embryonic life, and it has got 6 hillocks or swellings, which actually develops into the 1st and the 2nd brachial arches. During the fetal development, these hillocks rotate, fuse, and migrate dorsally and superiorly to form the ear. Normally, if you see, the 2nd brachial arch leads to the formation of the external pinna, and lots of abnormal development of the 2nd brachial arch leads to the malformation of the ear. At the age of 3, when if you see the lifespan, or if you see the growth of the ear or the maturity of the ear, normally by the age of 3, 85% of the ear development is complete, and by age 7 to 8, it is nearly fully grown. Ear growth continues into adulthood, but the width and the distance of the ear from the scalp changes a very little after age 10. And the main anatomical part, if you see, basically anatomy, when you do an anatomy, the surgery, or as a surgeon, the main thing we have to see is the helix and the antihelix. Why? Because it defines the real anatomical structure of a ear. So the helix, the antihelix, the scapha, the concha, these are some of the important landmarks which we consider when you do when you do an autoplasty. So I'm not going to deeply go into the anatomy. The ear is covered on both sides. Just to mention that the ear, the one speciality of the ear is covered on both sides by a thin, firm, adherent layer of perichondrium. So when you do a surgery in the ear, the first and main thing we have to address is how to dissect the perichondrium. And here comes the use of local anesthesia or tumescent LA. So normally, hydrodissection is one main thing when you do a autoplasty. So when you do a hydrodissection, when you inject the local anesthesia, one almost like 60 to 70% of dissection is being completed by the LA local anesthesia itself. So that is very easy when you do a hydro dissection using a local anesthesia. Subcutaneous tissue, when you consider, is practically non-existent in any ear. And however, a diffuse subdermal vascular plane exists that will support the flap viability. Friends, as you see, the blood supply of the auricle normally comes from two, that is the posterior auricular artery and the superficial temporal artery. And the nerve supply of the auricle is mainly comes from the greater auricular nerve and also the posterior auricular branch of cranial nerve or the facial nerve and the temporal branch of facial nerve. The proportions of an aesthetic ear. So when you are going to do a aesthetic surgery of an ear, you should know the exact proportion of a normal ear. So the normal ear, the proportion is, we have to consider some angles, and the main angle is the conchomastoid angle and the conchoscaphal angle. The conchomastoid angle and the conchoscaphal angle should be perpendicular to each other, and the distance and the angle formed by the conchomastoid and the conchoscaphal angle is called the auriculocephalic angle. So auriculocephalic angle is one demarcation or one main thing which we consider whether the ear is a protruded ear or a normal ear. So the auriculocephalic angle, if you consider, it should be like at the range of 25 degree for a male and 20 degree for a female. And the helical rim. So as you know, there is the helix and the antihelix. The helix which comes out or the outer border and the antihelix which is inside. So the helical rim should be seen just lateral to the most lateral presence of the antihelix from the frontal view. So when you look from front, you should actually appreciate the helix outward to the antihelix. And the distance measured between the helical rim and the scalp over the mastoid area should be slightly less than 2 centimeters. These are some ideal proportions of an aesthetic ear, okay? And the distance between the scalp and the uppermost aspect of the helix is approximately 1 centimeter. So what are basically the anatomic basis of a prominent ear? What are the different conditions where we can see a prominent ear? Normally, the main findings when you start looking into an ear, you will start finding the defects. So right now, as a maxillofacial surgeon, unless and until, just listen to my point, unless and until you start looking at an ear, then only you will start seeing the defects. So when, as a freshly passed out BDS guys, I still remember that we only see only the teeth. Whoever talks to us, our eyes will go only towards the teeth. So right now, when I started practicing otoplasty, right, my eyes goes only to the ears. So right now, whenever whoever I meet, I talk to them, I start commenting on their ears. Why? Because unknowingly my eyes are going to the ear. So basically, the main causes of a prominent ear are the conchal hypertrophy or the excess. So conchal hypertrophy can be in the upper pole, lower pole, or both. Second one is inadequate formation of the antihelical fold. So as I mentioned, there is the helix and the antihelix. So normally an inadequate formation of the antihelical fold is a very common finding here. And the third one is a conchoscaphal angle greater than 90 degrees. So normally, as I said, for an ideal ear, the conchoscaphal angle should be at least minimum 20 to 30 degree. That is for the females, it is 20, and the males, it will be like 25 degree. So if it is more than 90 degree, it is a very prominent ear or a bad ear, or a combination of a conchal hypertrophy and an underdeveloped antihelical fold. So what are the real goals of otoplasty? McDowell's, he has actually listed some basic goals of otoplasty. So, so when you do a surgery, these goals has to be achieved initially or finally after the surgery. First one is all upper third ear protrusions must be corrected. First thing. Second thing, the helix of both the ears should be seen beyond the antihelix from the frontal view. Third thing, the helix should have a smooth and a regular line throughout. Fourth, the posterior auricular sulcus should not be markedly decreased or distorted. This actually happens. That is the posterior auricular sulcus. When you do, we actually address or we actually get into the ear from the posterior auricular region. So when we do, a very tight suturing of the conchal cartilage with the mastoid fascia, what happens is that the distance or the posterior auricular sulcus is reduced, and which can lead to some untoward result. So we have to make sure that the posterior auricular sulcus should be actually some minimal space should be maintained even after the surgery. The helix of the mastoid, that is the distance, should fall in a normal range of 10 to 12 millimeter in the upper third, 16 to 18 millimeter in the middle third, and 20 millimeter to 22 millimeter in the lower third. This is the ideal distance from the scalp to the ear or the helix. So this ideal measurement should be maintained, and it can be changed or waived accordingly to the patient's demand. Why? Because since otoplasty or this surgery is being performed under local anesthesia, we have the advantage of asking the patient. We can actually give them the mirror, and we can ask them whether are they really happy with the result, or they can say that, okay, doctor, I'm quite happy. No, it has gone towards a little bit inside, so we can actually remove the suture and we can actually bring it out. Or if the patient is not so happy, the patient wants to get more inward, we can actually do it. So we have the flexibility of doing the surgery under the patient's demand. That is the best funda of performing this otoplasty under local anesthesia. And finally, the position of the lateral ear border to the head should match within 3 millimeter at any point between the two ears. So when you consider the surgical management, they are actually broadly classified into two basic categories. That is, one is the cartilage cutting technique, and the other one is the cartilage sparing operation. So when I started my initial surgeries in otoplasty, I normally followed one technique, that was cartilage sparing method. So I started doing cartilage sparing method, and I have done almost like 7 cases. After finishing my 7th case, my first case or maybe my second case has come back. That is maybe after 6 months, and asked me, doctor, I am not so happy with the result. That is, the ear has come out a little bit outside. So what I have to do is that I had to reopen it and I have to suture it back again. So one major disadvantage of cartilage sparing method is that the longevity of the result may be decreased. So what exactly is a cartilage sparing method? Cartilage sparing method was developed to decrease the incidence of the contour irregularities and maintain the structural support of the cartilage. Here only we will be suturing the cartilage with the mastoid fascia. So and the whole thing is dependent upon the sutures. So if something, if the cartilage memory might pull the cartilage outward, so that's why the longevity of the result may be decreased in cartilage sparing method. But on the other hand, cartilage cutting technique includes an incision or an excision or a scoring or an abrasion of the cartilage. The strength of the cartilage will be reduced by a scoring technique or sometimes an excision of the conchal cartilage. So one major advantage of the cartilage cutting technique is that there's a long-term stability of the result. The longevity of the result will be very high. And one disadvantage, what I find, is that the disruption of the cartilaginous support and the creation of a contour irregularity. Some kind of very minimal contour irregularities are visible when you do a cartilage cutting technique, mainly in the conchal area. So what is modern otoplasty? Modern otoplasty, on the other hand, favors a graduated approach in which they combine both the cartilaginous sparing technique and also the cartilaginous cutting technique. That is the suturing technique along with the cartilaginous cutting technique. So that is the modern otoplasty, which normally most of the surgeons right now follow. So what is the timing of the surgical intervention? This is a very confusing question. When exactly we have to start the otoplasty, or at which age we should start the otoplasty? Mainly, the indications of the surgery is to eliminate the psychosocial effect that the ear defect produces. So what is the psychosocial effect? The ridicule by the peers begins as an early age of 4 to 5 years during development, described as the body image concept. When a boy or a girl goes to the school, the first thing, if you have a bad ear or an outwardly prominent ear, the school friends started calling him with the name. If you say, I always tell in my videos, whenever I do a lecture on otoplasty, I say that I am having a bat ear on my left side. I think on my left side, I have a bat ear. So I have been I have been into this social bullying when I was there in my school. Anachevi. In Kerala, if you say that, we call it as Anachevi. That is elephant ear, but in English, it's like bat ear. So I had been bullied for my bat ear in my young ages. So that happens in lots of people out there. And this leads to the problem with the social adjustment, self-image deficit, and ultimately some kind of behavioral disorders. So most of the surgeons agree that the surgical correction of the ear can be performed safely between 4 years of age. That is before beginning of the school attendance, to avoid the ridicule, becoming one of the most common elective procedures performed in young children. So if you see, if a school going boy or a girl comes back to his house and he tells his mom or dad saying that, dad, my friends are calling me by this name, I want to get rid of it, or I'm so ashamed of having this, you have to convince the parents to get this autoplasty surgery done. So adults also present to correct a lifelong cosmetic defect. I have seen patients, girls, especially girls, who come to my surgical practice and say that their parents will be saying that she doesn't want to get married unless and until her bat ear is corrected. There are boys who comes after school who is not ready to go to college, and they say that I will go to college only after my bat ear is being corrected. That is the impact of a bat ear in their normal social life. So anesthesia. Basically, uh, autoplasty can be done under general anesthesia and local anesthesia, but my personal choice is always local anesthesia. And what we use is a 1% lidocaine with 1:1 lakh epinephrine. Or you can actually have some amount of tumescent local anesthesia also for this hydrodissection. Starting, the anesthesia normally starts in the area of the greater auricular nerve. That is 1% lidocaine with 1 lakh epinephrine is injected, followed by the posterior crease, then followed the concha, the lateral skin overlying the antihelical fold, and lastly, the conchal ball. During the infiltration of the lateral skin, that is outside skin, that is the anterior or auricular skin, greater care is used to try to elevate the skin from the underlying cartilage for two reasons. So basically the hydrodissection, that is done for two reasons. One is, if you're going for a later suturing technique, that is for a mustard suturing, when we are going to create an anti-helix, it will only, once the hydrodissection is happening, you can actually suture only the cartilage, leaving the skin. You are not going to touch the skin. And at the same way, the skin can be elevated easily off the cartilage in cases in which a rasping or a partial thickness incision is made. So this is a video where we give the local anesthesia. I normally use insulin syringe for delivering LA. This is also one of my favorite armamentarium, that is insulin syringe. I use a lot of, most of my procedures, I'll be using insulin syringe only. The ease of operation is very What is a tumescent local anesthesia? Tumescent anesthesia was first described in 1987 by Klein for the liposuction to prevent the copious intraoperative and postoperative bleeding associated with this procedure and to avoid the risk of general anesthesia. Since then, slight changes in concentrations have been made and it is being used in many other plastic and cosmetic surgeries. A standard tumescent solution is composed of a 500 milligram lidocaine, 1 milligram of epinephrine, and 12.5 milliaqueous of sodium bicarbonate added in 1 liter solution of 0.9% saline. The preparation used here in our cases is normally a lidocaine, a 0.05% to 0.1% with a lower concentration of epinephrine and diluted in 0.9% of normal saline. You can also use a bupivacaine, a 0.5%, which is acting a long acting LA. So basically, this is the marking, how we give. We do a elliptical shape of marking. It is an equal distance from the mastoid, from the scalp, and from the external helix. So we actually make it in a midway so that we can actually access both the area. That is, we can actually access the helix, and at the same time we can actually access the mastoid fascia. So we actually plan it or place it in between that is in the middle of the ear. So what is Furness technique? Furness in 1968 described his suture-only technique for the correction of the prominent ear deformity. This technique consisted of a posterior auricular approach, removing the skin, the connective tissue, and the vestigial posterior auricular muscle and its ligament down to the underlying mastoid fascia. Sutures are placed through the conchal cartilage and the mastoid fascia and tightened to the new desired retracted position of the ear. This remains as a very commonly used technique to set back the ear in patients with conchal hypertrophy alone. So this is immediately once the conchal cartilage or the cartilage is being exposed. As I said before, initially when I started my practice, I used only this Furness technique of otoplasty, wherein it's very simple. You can just finish off the surgery in half an hour. You just have to suture the conchal cartilage with the mastoid fascia. But the real problem with the Furness technique is that the relapse secondary to the cartilaginous memory. The cartilage, as you know, has got a very huge memory power. So even if you tie it very strong, the cartilaginous memory will pull it back. And a shallow conchal bowl is another problem, and the irregularities created in folding the conchal floor. Also, some chances of external auditory canal narrowing is seen when you actually place the conchal bowl anteriorly. So what is a converse Woods-Smith technique? This is another technique. The converse Woods-Smith technique is used to correct and create an anti-helical fold using a cartilage cutting and a suture method. So as I said before, not everyone will be having a conchal defects. For some, the defect will be just merely an underdeveloped anti-helical fold. So how to create an anti-helical fold is being explained by converse Woods-Smith. Once you open the cartilage or the concha is being exposed, several full thickness cut is being placed through the cartilage. As you see in this image, you can actually appreciate horizontal cuts has been made. Vertical cuts has been made just to make sure that the anti-helical fold is created. This full thickness, the cartilage is then folded. Once the cut is complete, the cartilage is then folded by itself and it is called as tubing. And a permanent horizontal mattress sutures are placed, forming a new helical fold. In addition, if excessive conchal cartilage is also present, you can actually do a little bit of cartilage incision at the rim of the bowl to reduce the bowl and retract the ear. The new anti-helical fold is formed, however, typically with sharp cartilaginous ridges seen through the thin anterior auricular scene. When you do a converse Woods-Smith technique or any technique for creating an anti-helical fold, the distance, that is, as I said, we have to do the cartilage to cartilage suture. That is, a horizontal mattress sutures has to be placed. So when you're doing the horizontal mattress suture, make sure that the distance between the sutures from one suture to the other suture should be at least a minimum of 7 millimeter. If you're not keeping that 7 millimeter distance, what happens is that the anti-helical fold will be like very sharp. That is it will be like very sharp. So what happens is that some kind of skin necrosis and unaesthetic, it won't be like very aesthetically pleasing. So always you should place at least like 3 to 4 sutures, and the suture should be distance between 7 millimeter apart. So what is Davis method? Davis method is one of my favorite technique, and this is the most practiced surgical technique right now in my practice. So what exactly is Davis method? Before I explain, I'll just demonstrate the video.
So this is the conchal cartilage. The procedure, what I'm doing is otoplasty, and the technique I normally practice is Davis technique of otoplasty. Here, I'm going to dissect, remove a small cashew nut shaped conchal cartilage so that the flexibility of the ear increases, and at the same time the longevity of the surgery, the result, long-term prognosis is really good if you remove a small piece of conchal cartilage rather than just the suturing technique. So once the conchal cartilage is removed, the stiffness of the conchal cartilage is relaxed, and I can actually easily suture the ear with the mastoid fascia. This is the separated conchal cartilage. So it has come out like a small cashew nut. So once the conchal cartilage is removed, see I have removed the conchal cartilage from here. So this technique of otoplasty is called Davis technique of otoplasty. And once this conchal cartilage is removed, the flexibility of the ear is very much, so that once you suture this ear with the mastoid fascia, since this cartilage is not going to pull this apart, the long-term prognosis is really good. So this is the whole funda of doing Davis technique, or the whole funda of removing conchal cartilage for otoplasty.
So friends, what is Davis technique? It is actually used for protruding ear caused by the hypertrophic posterior wall of the conchal bowl. The height of the conchal wall that will remain is marked, that is almost 8 millimeter, leaving 8 millimeter of the posterior conchal wall height, and the remainder of the conchal bowl to be excised is outlined, that is a kidney bean shape. The marking are then transferred to the underlying cartilage with a methylene blue tattooing. Local anesthesia is used for the hydrodissection of the highly tightly adherent anterior auricular skin along the conchal bone. So normally, once we make the incision, we have to make sure that in the anterior region. So this is, we have to leave almost like 8 to 10 millimeter of the posterior conchal wall should be intact, and the rest of the concha should be removed or excised in a kidney bean shape. So the marking actually is being transferred using the methylene blue, and the transferred image is completely being dissected. The concha is exposed through the posterior auricular incision, and the cartilage is incised through the areas tattooed, leaving the anterior skin intact. The subperichondrial plane of dissection is developed and the cartilage is removed, leaving the 8 millimeter of posterior conchal wall. The ear is then placed passively. So as I said before, once the cartilage is being removed, the ear becomes very passive. There is no cartilage or a conchal cartilage which has got that image, that is memory of the cartilage's memory will be completely devastated once you remove the conchal cartilage. So it passively gets adherent to the mastoid surface. The new projection is inspected. So whether the projection, as I said, the ideal measurement, that is 10 millimeter the upper middle pole, that is 16 to 18 millimeter, and 20 millimeter in the lower pole. So this is it being inspected, and if at all any changes has to be made, we actually does it. The posterior post-auricular muscles and the underlying connective tissues are removed down to the underlying mastoid fascia. And how we can actually identify the mastoid fascia? When you do the dissection, you can actually see a white sling-like structure, which is very visible when you do the dissection. So that white sling is the mastoid fascia. The ear is fixed into its new position with 4 mattress fixation sutures using a 3-0 silk, which goes through and through and tied over a cotton dental roll for compression. So that this is the way which we do the mastoid to the concha suturing, and we place a cotton roll, and the cotton roll is there for almost like 2 weeks. And also a cotton roll is also placed in the ear canal to prevent stenosis. The post-auricular incision is closed with a non-absorbable suture, leaving a small opening inferiorly for the drainage. The dressing is removed in 2 weeks. So if you ask me, I normally suture it with a non-absorbable suture, and I don't normally give a drain. In my practice, I don't give a drain, but the sutures are very loosely as approximated. It won't be that very tight, so that if at all any kind of fluid accumulation, it will be actually drained by itself. So I normally don't give a external drain. So this is the elliptical kind of posterior auricular marking which I do. So these are some of the pre and post results. This is immediately after the surgery. Okay, this is immediately after the surgery. This is how the result will be. And one beautiful thing about the surgery is that the scars, there won't be any scar actually. The scars are very minimal. The patient or nobody will be able to appreciate if there is any surgery has been done or not. This was very recently. These 3 cases actually I did last week, maybe in 10 days period. So these 3 cases came to me. So right now the number of patients coming from autoplasty, I have like patients coming from all over Kerala. People started knowing that such surgery is being happening. So my main advice to all the surgeons out there is that you should actually start promoting autoplasty. Why? Because most of the majority of the population out there doesn't know that who is actually supposed to do an autoplasty, or any surgeons in India is performing autoplasty. So when you start marketing autoplasty, or when you start talking about osteoplasty, there are tons and tons of cases out there in our society. This is yet another case. So normally what I do is that once the suturing is done, I send back the patient. I'll be giving like 5 days of antibiotics. I recall them after 7 to 10 days, and I'll be removing intermittent sutures. Not all the sutures will be removed. I'll be removing intermittent sutures. Then after 1 more 7 days, I'll be removing the whole suture. That is how I practice, which is my way of practice. I'm not sure that whether it is right or not, but this is the way I start practicing. So one other technique is the mustard suture technique. This is for creating the anti-helical fold. So mustard suture technique is otherwise a cartilage weakening technique, and it is usually used for a properly formed or lacking anti-helical fold. It is commonly used along with the Davis method. The anti-helical fold marking is firstly done. The scapha, that is the curvature in between the helix and the anti-helix, is folded back against the underlying scalp by applying a digital pressure on the superior helical rim, which creates the anti-helical fold. The crest of the fold is marked with a surgical marker to prepare for the placement of the mattress sutures. Marks are placed parallel to the crest at least 7 mm apart to avoid creating a too narrow a fold. This I have mentioned before. That is, the marking should be apart like 7 mm apart, so that it's not folded very tightly and it's not very acute. The curve should be like very obtuse. It should not be like very sharp. The lateral marks placed on the skin are then transferred to the underlying cartilage with a hypodermic needle dipped in methylene blue. Dissection and the cartilage weakening. The posterior auricular skin is then removed in an identical fashion as described by the Davis method. Once having identified the marks placed on the posterior surface of the scaphoid cartilage, we make actually a horizontal cut in the anterior auricular skin. Once the horizontal cut is made, we insert actually a Brown's-Adams forceps or a nasal rasp or a dermabrader is done to do the cartilage weakening. So as you can see the image, I don't have my surgical images for this one. So normally a rasper is placed and we actually weaken the cartilage, or a simple Brown's-Adams forceps can be used, and actually we can press the cartilage. So when you press the cartilage, it becomes very thin. It becomes like a chapati. If you say it becomes like a chapati, and the memory will be lost, and we can actually tie it and gives a tunneling effect or a tube effect, and we can actually give a wonderful anti-helical fold. Normally the suturing is done with a 4-0 non-absorbable suture, silk suture. The suture should be placed perpendicular across the antihelical fold so that upon tightening, a well-rounded antihelical fold will be created. The sutures are then tightened under direct observation and adjust accordingly to form the new antihelical fold. The sutures are tied simultaneously and not under full tension. So what are basically some of the important post-operative care? Applying antibiotic ointments on the suture line and dress the incision with a non-sticky gauze pad. Wrap the head with an elastic bandage. Why an elastic bandage? Just to avoid the edema, which goes toward the mastoid region and towards the parotid region. Wrap the head with an elastic bandage. Discharge the patient home on 1 week of oral antibiotics and analgesia. The purpose is to protect the repair, keep the skin of the ear moist and absorb drainage. No attempt is made to put pressure on the ear. A donut of gauze is placed around each ear specifically to avoid pressure. The dressing is left in place for 3 to 5 days. So, and if you ask me, I normally ask the patient just to keep the dressing for a day, or sometimes I even send them back without even any dressing. Why? Because in my experience in past 2 years of otoplasty, very minimal side or very minimal side effects have been come. So there is normally no chances of infection is very minimal. So only thing is that the patient will have some kind of edema, that is for a couple of days. Just for a couple of days, there will be edema, and a full course of antibiotic will completely cure it. So what are the different types of complications? Basically, there are 2 types of complications which we see, that is the early complications and the late complications. So the early complications are like hematoma, bleeding, skin necrosis, wound dehiscence, and wound infection. And the late complications will be like hypersensitivity, scarring, asymmetry, unsatisfactory aesthetic results, and suture extrusion. So what are the immediate complications? So immediate complications of it comes in between the day 1 to 5. So basically, hematoma is one immediate post-op complication. The patient might experience tightness, some kind of pain, or increased fullness of auricle, ultimately leads to a cauliflower like an ear. Is management of a hematoma is like prompt evacuation, place a drain and a pressure dressing, and administration of antibiotic. So always make sure that you give a very not a very tight suturing. You should have a suture line in which some kind of fluid extrusion should be possible. Infection mainly arise from the skin or the underlying cartilage, or secondary from fluid collection such as hematoma. Infection may present with pain, erythema, swelling, and drainage. Management includes drainage and irrigation of the wound, followed by treatment with oral antibiotics, anti-pseudomonas antibiotics, or if there is severe infection, you can actually give an IV antibiotic. Late complications. So some of the late complication is loss of correction or relapse of the auricular deformity. The relapse of auricular deformity occurs mainly because of the cartilage sparing technique, as I have mentioned before. So in cartilage sparing technique, we solely depends on the sutures. So if there is, it's a non-absorbable suture anyway, but the thing is that the cartilage memory will actually pull it out. There are multiple technical causes of inadequate correction. One is including the pulling of sutures over time, improper placement of the sutures, failure to correct the deformity during surgery, failure to anchor sutures firmly on the mastoid periosteum, and failure to weaken non-compliant cartilage. So what is the last untoward result? We have to open it, and when you open it, make sure that you don't have to face any more complications. So in such cases, in my experience, I have opened one case in cartilage sparing technique, and from that case, that was during my 7th case, when I finished my 7th case. From there onwards, I always started practicing Davis technique. I don't do only suture technique. I always make sure that I do Davis technique, so that the results and the prognosis are good. From there until my 25th case, which was done last week, all my cases I used to do only Davis technique. One another thing is that hypertrophic scarring and keloid. The posterior auricular area may develop some kind of hypertrophic scar or keloid, especially in patients with darker skins, younger patient, or patient with a history of hypertrophic scarring or keloid. avoid unnecessary tissue trauma and ensure a tension-free closure. And if there is by chance any kind of keloid or scarring happens, it's always better to give a triamcinolone injection every 4 to 6 weeks. What is telephone ear deformity? Telephone ear deformity, normally if you see the picture A depicts a normal anatomy, picture B wherein it is almost like a telephone. So it's like a normal old telephone which we use in our home, that is with the overcorrection in the middle third of the ear and a relative undercorrection of the superior and the inferior part. In such cases, you will have a telephonic ear deformity. What is the reverse telephone ear deformity? Occurs when the middle third of the auricle remains prominent relative to the superior and inferior poles. Both these deformities are avoidable with correct placement of the conchal setback sutures. So once you do the surgery, you should make sure that you should actually ask the patient to get up from the table. Okay, what I do is that I ask the patient to get up. I make him sit in the sitting position and I assess it. So if there is some kind of changes we have to make, we even ask the patient, we give the mirror and we ask them. So if there is some kind of corrections in this view, in the frontal view, you can actually correct it on the table only. So always make sure that you should actually ask the patient to get up in the OT table and you should see them actually the frontal view so that you can do any correction before closing the wound. And one major complication is like narrowing of the external auditory canal. This may be seen after conchal setback with an improperly placed sutures. Once you do the conchal setback sutures, sometimes there may be some kind of narrowing of the conchal.
जैसा बोल्ड मार दिया उसने, देखा नहीं तूने बुमराह ने 3 डंडे गिरा दिए.
When placing furnace conchal setback sutures, care must be taken to pull the concha superior medially to avoid the canal narrowing. So friends, if I can do it, you can do it and anybody can do it. So better you start seeing orthoplasty cases or bad ear cases in your practice. There will be like thousands of patients out there. Only thing is that you have to open your eyes and start seeking for bad ear surgeries. Thank you. Hello.
Yeah. Thank you, Varun. If there are any questions, please share it in the chat box. Dr. Vin, you can take over.
If there are any questions, you can feel free to unmute and ask, or you can put it in the chat box. Anyways, it's fine.
Yes, boss. Excellent presentation. Dr. Usama Vissar from Egypt, ENT consultant.
Thank you.
Yes. Fortunately, the series we do at our hospital is done by plastic surgeon, but we have a little bit experience in doing otoplasty by the sutures. When you resort to the Mustardé or cartridge sparing method in doing otoplasty, what are the criteria you choose between cartridge sparing and just the suturing?
What are the criteria?
Yes, when you resort to that and that.
So basically, when you start looking into different types of ears, right, you can actually see that there are some kind of ear, which is the cartilage will be like very thin. Okay, so the thickness of the cartilage does matters. So if the thickness of the cartilage is very thin and it's very flexible, you can definitely go and do a cartilage sparing technique. There is nothing, it's not going to create any kind of relapse. But in some cases, the conchal cartilage will be like very thick. And the memory, if you pull down, if you just before surgery also, if you just push the ear down, it will just revert back in a like a bullet. So in such cases, the thickness of the cartilage is a matter of concern. In such cases, it's always better to do a cartilage removing technique.
Spare. Yes. And the final result, when you are confirmed that the result is better, after 1 year, after 6 months, when?
See, results are, see, anyway, after surgery, you have to inform the patient that even if you do a cartilage sparing or cartilage cutting technique, at least minimum 2 millimeter to 3 millimeter relapse is there. Anyway, it will be there. Okay. Why? Because it is unavoidable. So what I
So
do.
you do overcorrection.
Oh.
So you do overcorrection first, or
I do a little bit of
the...
overcorrection. I do a little bit of overcorrection.
Yes. Yes. Thank you, sir. Thank you.
Yes, sure.
Thank you.
Are there any other questions to be asked?
Vineesh, there
shall
are a
we-
few questions in the chat box.
Yeah, so Dr. Varun, Dr. Om Prakash has asked about what is our eligibility as OMFS in doing these procedures, and is there any criteria in defending in the court of law? I maybe you would know about it.
I think that's a question for George Paul,
George
sir.
Paul, sir.
Sir is still here. He can answer that.
Sir, I think in Indian medical, to my knowledge, okay, limited knowledge, what I feel is that most of the topics which are there in our curriculum, we can actually freely practice in India. So since autoplasty is very well there in our curriculum, I think performing an autoplasty doesn't have some legal, any kind of legal issues. To my limited knowledge, I'm not very sure, but I think we can do it.
Okay. So, and Dr. Karthik Chandravat had asked about what are the vital structures that you should take care of while doing the procedures?
See, basically, when you do the nerve innervations are like very thin innervations, so there is no major structures when you go inside the ear. The only thing is that when you do the mastoid dissection, when you're going towards the mastoid fascia, make sure that your instrumentation or your armamentarium or the dissection should be like with using a blunt dissecting scissor. You should not use a very sharp instrument, and when you start dissecting, only the mastoid fascia is way there welcoming you. There is no vital structures out there which is going to create any kind of issues when you as a beginner also. Nothing is there to create any issues over there. So you just have to use a very blunt, nice dissecting scissors, and make sure that you do a lot of hydro dissection. So that's why I told you can actually try a tumescent LA along with the local anesthesia. So once you use a tumescent LA local anesthesia, most of the hydro dissection part will be done by it. So once you open it, it will be like all free of blood, and there's no vital structure which is going to create any big issues for you.
So this hydrodissection with local anesthesia, it's like a local infiltration. Do you have to give a local infiltration separately, or you directly go for?
So first, normally I give a local anesthesia in 3 areas. One is the posterior auricular nerve region, the conchal region. First, initially, 2 ml, I give a 2 ml, 2 ml, 4 ml syringe. Then after that, then I give the tumescent LA. Normally, what you use in hair transplant, we use the same thing.
Dr. Tangavel had asked about while doing hydrodissection, when the perichondrium is separated, do you have you seen any case of perichondritis, and if so, how do you manage it?
So to my experience, I haven't experienced any complication. One complications, not a very serious complication. What I've seen is that normally once you do this conchal cartilage excision, right, there is some kind of hematoma and collections will be there. So one patient has come back with a collection, no perichondritis to my experience till date. and I always make sure that the suture is not very tightly placed. So what happens that the pressure from the tissue, the fluid collection is completely avoided. So so normally the patient might complain that I have bleeding for 1 or 2 days. That's actually not the bleeding, that the fluid evacuation. So once the fluid evacuation is happening, I'm so happy. I'll be like very happy if the patient calls me and say that there is fluid, the blood is coming. In fact, it's the fluid going out. So I'm so happy about it. No perichondritis to my experience yet.
And in your practice, it's from me, in your practices, have you seen what sort of complications have you seen? And what do you think is the reason and how did you manage?
So I didn't get you, sir. Sorry.
In your practice, in your experience, have you seen what is the thing that concerns you the most in complications? Or what has troubled you? Has anything troubled you?
To my experience, I haven't experienced any very serious complications yet. Only thing is that fluid collection has been one problem. There I had to open it up in one patient. Then I had to reopen one case because of this cartilage sparing technique. I had to redo with the Davis technique. I had removed the conchal cartilage. So this is the two things which I had experienced in my practice.
Okay. So is there any other questions? You said you remove sutures after 2 weeks. Have you come across any complication by doing it? There's a question in chat.
No. I haven't.
Maybe the participant wants to ask in detail about the question. What should be the charges?
That's a very serious question actually. I'll tell you, sir. Very recently, one of my friend, what my charge is that I will tell you. Initially, I used to charge like one per year. I used to charge like 20,000. I started with 20,000 for 1 year. Okay, one side. So now I started increasing it to 40,000 for 1 year. So that is like 2 years. I charge 80,000. And the funniest part is very recently, one of my surgeon, my best friend, so he is working in a hospital. So he had seen his ENT surgeon. So he knows that I am doing autoplasty. So we have been discussing about autoplasty. And I heard that his ENT counterpart is doing autoplasty and they charge 4,000 rupees for an year. So I found it very funny. But my point to you is that patients are actually ready to get it corrected. So you can even charge like 1 lakh rupees, 2 lakh rupees to accordingly to your practice. But right now I'm charging like 80,000 for this procedure.
And anything else about the recording? We'll let you know. Some of you have asked about recordings, whether it is available. We'll let you know.
Okay, sir.
Okay, Dr. Varun, thank you for enlightening about a very niche specialty. This is like in my practice, this is the first time I'm hearing about autoplasty actually, and so it actually opens up a scope. We are actually thinking in a very small area. Thank you for broadening our vision.
Hello. Sir, can we go for the endoscopic procedure in the same way regarding this endoscopic assisted autoplasty and all?
Sorry, yeah, I don't have much idea. Why? Because since the whole thing is being done in the posterior auricular area and the scarring is very minimal, and we have to actually go and remove the cartilage, everything. I don't think endoscopy is required, but I have very limited knowledge about endoscopic surgeries regarding autoplasty. I'm very sorry about it. Sorry. And as as the moderator has told, see, this is actually a huge scope is there. So only thing is that most of the majority of the maxillofacial surgeons have actually not seen this opportunity. So that's why the relevance of this topic is very high. So every maxillofacial surgeons who have attended this seminar or this talk, you should actually start, or at least you should start seeing cases, and one fine day you will get one case and you should start doing it. And I think it is very easy, very simple.
Is there any fellowship to practice? Dr. Varun, I'm sure you are having some programs in mind.
Yeah, if the AOMSI Kerala, in association with AOMSI Kerala, if they are actually letting me, I'll very happily want to start a master class in such surgeries, aesthetic surgeries like autoplasty, then blepharoplasty, then rhinoplasty under local anesthesia. That I'm going to plan it, but only with an association with AOMSI Kerala. So if they permit me, I will definitely start my course very soon.
Don't say they, Varun. You should say we.
We, yeah, sorry, sir, we. Sorry, we.
I think we can wind up further this thing. Anand, can I trouble you for a vote of thanks? Dr. Anand? Is he there? I think Anand's microphone is muted. So Dr. Varun, thank you so much for an enlightening topic, for selecting a topic which has so much this thing. And I think, like you said, a lot of maxillofacial surgeons should go into autoplasty now, start doing back ear corrections or elephant ear corrections. Thank you for bringing this particular topic to our attention. And Dr. Vineesh also, thank you so much for moderating the session. And thank you, special thanks to all the participants and for your questions regarding the topic. And definitely we'll share it. We have recorded the session. We'll definitely upload it in 1 or 2 weeks, and we'll share the link also. So thank you all. We'll be having another webinar on the next week or so. So thank you all for joining. Have a good night. Thank you, Varun, once again.
Thank you, AOMSI Kerala, for giving me an opportunity. Thank you so much. Thank you, Vineesh. Thank you, Akhilesh sir. Thank you, everyone who has attended this seminar. Thank you so much. Have a great day. Good night.
Good night.
Good night, everyone.